Good morning, everybody, and welcome to Tuesday's Talking Cafe. My name's Mickey Scott. I'm one of the village agents covering the Taunton Deane area. I've kindly been joined this morning by Teresa Davison from the Somerset Menopause Clinic, who's going to talk to us a little bit about menopause, awareness, the support that's out there. If you do have any questions during this chat, if you want to pop them in the comment box, and we'll get round to answering them even during the chat or towards the end of the chat. Good morning, Teresa. Thank you for joining us.
Morning.
If you want to go ahead and
Go ahead.
explain what you do, and I'll put myself on mute so it doesn't interfere, and I'll be here if you need me.
Lovely, thank you. Thank you. Morning, everybody. Morning, everyone out there who's listening to me now and who's going to listen to me later on. And thank you, Mickey and the Talking Cafe, for inviting me to talk about my passion, which is menopause care. As Mickey said, I'm Teresa. I'm a nurse practitioner, historically from primary care background, which is GP land, specialising in women's health for many years, and probably for about the last 12 years specialising in menopause care. And it has become what I do most of the time. So a couple of years ago, I opened my own clinic here in Taunton in Somerset Menopause Clinic, with a view to helping women by giving them more time. And not that I can provide anything that your GP can't, but the fact that I can give women more than 10 minutes, which is what this area of care needs. So menopause isn't just a medical condition, it's a personal experience, and it affects a lot of people. It obviously affects the lady who's going through it, but it affects everybody else at home. It affects relationships, it affects children, adolescents, and it affects us in the workplace. And it has never been given very much recognition. It has been very much brushed under the carpet. You may have noticed over the last few years, or perhaps the last couple of years, that it has become a bit of a buzzword. There's much more out there on it now. Magazines have got information on it. There are websites. Mickey is going to point you to some websites, some safe, reliable websites for you to look at after this. It's much more talked about than it was, but we're still not there yet. And I often think women have 2 or 3 hormonal journeys in their lives. So all young girls will start their periods, some women will have pregnancies, and all women will go through the menopause. Some will hardly notice, some will be really debilitated by it. The first 2 of those journeys are given a lot of recognition and respect, a lot of congratulations, a lot of help and support. And this last one is brushed under the carpet. It's a bit embarrassing. No one wants to address it. No one wants to talk about it. And it causes people a lot of problems. So whilst you can go to your GP for menopause care, and that's absolutely what you should do as a first port of call, there are going to be GPs who are absolutely brilliant with menopause care, but GPs have to know an awful lot about an awful lot of things, and menopause understandably doesn't come very high on their agenda, because there's a lot of other more urgent work that needs to be done in general practice. So as I said, the ethos of my clinic was really to give women time and to give them more than 10 minutes. So I'm going to start with what is menopause, and I'm going to talk about the various stages of it. Some of you out there may recognize things that are happening to you as I talk. Some of you may panic and think, oh my goodness, is this all going to happen to me? So don't be one of those people. Not everybody gets all the symptoms, and some people hardly are aware of symptoms. It's just about being aware of it. And just a quick disclaimer that I should have said at the beginning. So the information I'm going to talk about today stands evidence-based today. Things change. So if I'm giving you statistics and figures and risks and benefits, that's how it is now with scientific evidence. But if you're listening to this in 6 months' time, there may have been something else that has crept in or that we are not aware of now. So just so that people are aware of that. So the stages of menopause are complicated in terms of diagnosis. Out in the world, we talk about menopause being the change, going through the menopause, feeling menopausal, all those sorts of things. In clinical terms, we talk about the premenopausal woman being from the day the young girl starts her periods in her teenage years, right through until 12 months after the last menstrual period. And the average age for that in the UK is 51. So it's a retrospective diagnosis, and it's a tricky one. And some of you out there will be thinking, well, am I there? Am I not? Some women carry on having regular periods until they're in their late 40s and their early 50s, and then their periods stop. Most women will have erratic periods in that time where they might go closer together, then they might go a few months without one, and they might be thinking, here I am, I'm on my 12-month journey, and then it all starts again. So it is worth keeping a record of it, because as we know, it's very easy to think, oh gosh, that was only a couple of months ago, when it actually was about 9 or 10 months ago, as with everything in life. So postmenopause is diagnosed 12 months after the last natural period, unless you have a surgical menopause where the lady goes to theatre for an operation and has a hysterectomy with her ovaries removed, or has a hysterectomy so that she's no longer having periods. So there's a natural menopause and there's a surgical menopause. And for most women, it will happen near the age of 50. But remember that if average is 51, there are going to be women who carry on having periods right into their late 50s. There are going to be women who stop much earlier. And interestingly, 1 in 100 women will have their menopause before they're 40. Those women need a lot of extra care and a lot of extra listening to, because it may not be anywhere near their radar to think that that's why their periods may have stopped. Then there's the complication that a lot of women going up into their early 50s are on hormonal contraceptives which stop their periods. So there'll be lots of people out there thinking, I've got no idea when I last had a period. I don't have periods because I'm on the pill that stops your periods, or I've got a coil in that stops my periods. So that complicates issues further. So we deal with the average being 51. Then we have the perimenopause, and the average age for perimenopause is 45 to 55. And this is where things, as an average, start to change. So instead of you having a lovely cycle of estrogen that sort of goes like this, different times of the month feel different, your estrogen starts to deplete gradually. And it doesn't do it slowly, gradually. It does it in a sort of jagged, almost like a staircase effect, erratic. And it gives you these fluctuating levels of estrogen which start to cause symptoms, which we're going to talk about in a moment. And you may only have a few symptoms to begin with. You may hardly recognize them. They may not bother you. They vary, as I said earlier, from women who are just slightly aware to women who find that their whole life pattern at home and at work is debilitated. So that is average 45 to 55. Remembering, of course, it's going to happen to a lot of women in their 40s, and it's going to start happening to a lot of women in their 50s. And interestingly, commonly the symptoms start 18 months after the last natural period. So I see a lot of women who come in and see me and say, I haven't had a period for nearly 2 years and I've been absolutely fine. What is happening now? They have completely discounted it because they've done the menopause. It's over. They haven't got to think about it. So symptoms can start when you're having regular periods every 4 weeks. They can start when your periods start to change and become erratic, and they can also start long time after your periods have stopped. And as I say, we're going to talk about the signs and symptoms in a moment. Treatment for menopause needs to be bespoke. My mission is not to get every woman I see onto hormone replacement therapy. We're going to talk about hormone replacement therapy and the pluses and minuses that go with it. My mission is to get it out there as to what women can do, so that they know about different things, particularly about HRT with the bad press we've had in the past, and whether it would be safe for them. It's not about everybody having to take the same thing. And treatment needs to be bespoke for different women, because different women have different needs and different things that will bother them. So let's talk a little bit about the signs and symptoms of menopause, of which there are many. And if you go on the Menopause Matters website, you will see that you can look at an A to Z of menopause symptoms. And as I said, don't be worried that you're going to get all of them. As our estrogen starts to deplete, we can get any or all of symptoms, the most definite one being what we call as clinicians vasomotor symptoms. So this is when your thermoregulation goes wrong. And it's not the only symptom of menopause, it's not the only symptom deserving of treatment, but it is the symptom that brings most women in to ask for help, because it's definitive. Whereas all the other symptoms that we're going to go through are pretty much towards lifestyle and what's going on and not going on and stress related. So you may not even have thought about it being to do with your hormone cycles. So what happens when estrogen starts to deplete is the chemical messengers in our brain, noradrenaline and serotonin, which are responsible for thermoregulation, can't work as well as they could. It is thought that with lower estrogen levels, they just can't quite do it. So we start to get We can be hot when everyone else is cold, cold when everyone else is hot, and we start to get these hot flushes and night sweats. Some women get them very definitively. They absolutely know what's happening and describe it as a hot feeling that starts in their chest, goes straight up to their head and down to their feet, and it happens again at night. Some women just feel warmer than they want to feel, and they're sort of sitting there in a vest when everyone else has got a coat and a scarf on. These are still vasomotor symptoms. They happen during the day and they happen during the night, and they are related to anxiety. So if you get a hot flush for which you have no control over, and let's say you're doing what I'm doing now, you're sitting at work, or you're even trying to do something nice with your family or whatever, you start to get a hot flush, it's going to make you anxious, because you're sitting there thinking, do I look bright red? I'm starting to perspire. People are not going to take me seriously. There is a link between anxiety and hot flushes. So as you're having that hot flush, you become anxious. The more anxious you become, the more likely you are to get a hot flush. So for some women, they are repeated and they carry on all day. There's no sort of maximum you can have in a day. It's not as though if you get your hot flush at 9 o'clock, you've done it for the day. You don't know how that's going to be and how it will pan out. Then there are night sweats, which wake women up at night. And one of the other symptoms of menopause is poor sleep. Women who go to bed really tired can't go straight to sleep and then wake up and are awake for several hours in the night. That also links in with anxiety, because anxiety is increased with estrogen depletion, and therefore we're awake in the night. We maybe that the hot sweat has woken us up, maybe that we've just woken up. Now we're lying awake and we're really anxious, and we start to overthink everything. And the overthinking and the anxiety is one of the biggest symptoms. It's a very difficult symptom to live with. Sometimes with the anxiety, we get palpitations. So we lie there listening to our heart rate going perhaps a bit faster than usual, and we start to worry about that. And then there are a myriad of other symptoms like aching joints, feeling tired all the time, low mood. Some women even describe feeling depressed, irritability, flying off the handle, just feeling hormonal and not feeling right, itchy skin, dry skin, loss of energy, loss of excitement, loss of sex drive, uncomfortable sex, feeling very uncomfortable in the vaginal area, dry, like we get dry skin, all sorts of things that women perhaps haven't spoken to anyone about because they feel it's natural and this is what has got to happen. I've posted a book on the chat column there for you to have a look at. I'm not on commission, but it is such a good book. And I think if you read it, what it will do for you is it will normalize the menopause. And what it will make you realize is that you're just the same as everybody else. We've got to talk about it. And that's where we're going wrong. If we all start talking about it to our friends, to our sisters, to our partners, whether they're male or female, to our daughters, this sort of thing, we will spread the word down, and then future generations will have knowledge about the menopause that my generation have not had passed on from our parents because it wasn't spoken about. So I suppose you'll be sitting out there thinking, well, when should I go to the doctor? Yes, I have had a hot flush. Yes, I am anxious all the time. When should I go to the doctor and see if it's all about my menopause or if it's just about the fact that I'm really busy at work and it's all been different in COVID? And we've all had to learn to do different things like this, which has been no easy task, I would say. So lots and lots of stress that goes on in life anyway. So will the doctor just think, well, yeah, you're tired, you're stressed, you need a holiday. We all do. We can't go away, that sort of thing. I think it's about looking at where you are, how old you are, what your cycle is like, whether it's becoming erratic, whether your periods are becoming heavier. It's about talking about all those things. And I think going to talk to your doctor about being in the perimenopause and having symptoms is very, very important. So in you go to see the doctor, and you may say, well, my biggest symptom is the hot flushes and night sweats, but my grandmother had breast cancer and I know that I can't take HRT, and we'll come back to that. You may say, I think my worst symptom is that I'm depressed and I'm irritable. I shout at everybody all the time. I can't sleep at night. That makes it worse. And your doctor may say to you, what about having an antidepressant medication? Because this could be good for you. Antidepressant medications are fantastic. I'm not here to say that they're not, and they are wholly appropriate for lots and lots of women. But the NICE guidelines say that for women who are between the age of 45 and 55, who have symptoms of the menopause, one of them being the low mood and the anxiety, the best possible treatment, provided it's safe to give it to that lady, is hormone replacement therapy. because it is your low mood and your feelings are because of your estrogen depletion and those fluctuating levels, not necessarily because of anything else. But that's, of course, a decision that you make with your prescriber. I'm not here to tell anyone what to do. If you're my client, that's different, but I'm just here to say, go and talk to your doctor about it. So you may go in with loads of symptoms, you may go in with one symptom. It may be something you mentioned to your nurse when you're having your cervical smear done, and these things come, these little conversations come up, and it may be that you'll go away from this talk thinking, yes, I think I have got quite a few of those things. And it's about how you cope. So are you coping at home? If you're in those perimenopausal years, it's quite likely that you're in between looking after lots of different people and lots of different parts of your life. So you may have elderly parents who need help, elderly relatives. You may have adolescent children. You may have children who've just left, giving you your empty nest thing, which also comes hard. You may also just be very busy doing everything and learning things with all the way that we're working at the moment. And it's hard to really put those things into boxes and to know which is the chicken and which is the egg. But without a shadow of a doubt, there's always going to be stress in life, and it's how you manage that. And then there's coping at work. How do I approach my manager with this? If I was pregnant, somebody would make sure I had a glass of water, make sure I sat by the window if I felt a bit hot or a bit faint. How do I tell someone, particularly if my manager is younger and hasn't been through this, perhaps also if they're male and they haven't got much understanding, that's not their fault, that's because it's not out there. How do I say, look, I just need to step outside every once in a while just to get a bit of air. I need to sit by a window even though it's a bit cold in here. I don't always concentrate really well and I may lose my train of thought. One of the most difficult symptoms for women, particularly in the workplace, is loss of the practice effect. And the practice effect is something that we have, things that we do all our lives. We can do them with our hands in our pockets, with our eyes closed, and then they become tricky and we can't remember. We can't remember the password, even though we know it. We can't remember the directions to go somewhere. We can't remember someone's name when we've just spoken to them. And it all adds up to giving you a loss of confidence, which then escalates into anxiety. And all these things become a vicious circle. So it's about how you approach your manager. And I would urge all of you, wherever you work and when you get back to the workplace, to talk to your managers about menopause being part of a need in the workforce. And if you think, half the workforce are women, women are going to lead a third of their lives now in their postmenopausal years and are likely to be affected by this. And women in their postmenopausal years are going to have an awful lot of experience in the workplace that we don't want to lose. So talk to your managers and say, can we have a little sort of a space in our coffee room where people can pick up leaflets? Can we have someone come in and do a talk like this to talk to us about how we're feeling? Make sure that you feel okay about talking about it. Try not to make it embarrassing. It's really hard, and it's really hard to overcome that. So coping at work and coping at home might just be for you putting in coping strategies, but it might be that you've now decided, I'm going to go and talk to somebody about this. I think I need some help. So let's begin with lifestyle help. So the best possible thing we can do for ourselves is improve our overall health. We all know that, don't we? We can exercise, we can try to stop smoking, we can drink alcohol within safe limits, and we can try to maintain a healthy weight. If you do all of those things, then you're already more than halfway there. If you're doing all those things and you're already in that situation, or you can't do all of those things because things are not always, it's not as easy as me sitting here saying, don't drink 3 bottles of wine at the weekend, get out there running, do this, do that. Not everybody can do all these things. If your lifestyle choices are already in a good place and you've got symptoms, you definitely need to talk to somebody about what you can do further. But we all need to maintain those lifestyle things because they all give us risks for any kind of thing that we're doing in life. Then there is treatment that comes over the counter. So what we call natural remedies, and there are plenty of them out there on the shelves, and I don't knock them. I think I meet lots of women who take over-the-counter supplements that make them feel better. What I would just say to you is that when you are investing your time and your emotion, and particularly your money in these things, just be aware that they are not regulated by the Medicines Health Regulatory Authority. It doesn't mean they're not going to work, but when we are given a prescription by a doctor or a nurse, or actually even if you buy a medication like paracetamol over the counter, it comes with a leaflet of paper in it that tells you what it's going to do to make you feel better, but also all the awful other things that could happen because you're taking it. The reason that a lot of the over-counter products don't come with this, some of them do, but the reason a lot of them don't is because they haven't had trials and haven't got trial data to support that although your hot flushes might get better and your anxiety might get better, this might also happen. So just be aware of it. Don't stop taking it if you're taking it now and you're feeling better. I think that there is definitely a place for it. You can imagine that by the time most women come and see me, they've tried these things, especially those who don't want HRT. They've been through absolutely everything. They've tried the over-the-counter herbal remedies, reflexology, homeopathy, there's magnet therapy, there's CBT, which is cognitive behavioral therapy. That can be really, really helpful. You know, that's talking to people about your anxieties and your concerns about yourself, a bit like I'm talking to you now. Making it real, making it normal can really go a long way towards making you feel better. But by the time ladies come to my private clinic, they have usually tried all these things. They've perhaps been to their GP and talked about HRT, and perhaps it hasn't felt like it's suitable. They may already, I get plenty of ladies who are already on hormone replacement therapy who've been given that by their GP and are perfectly happy with seeing their GP, or their care is really good, but in a 10-minute appointment they can't ask all the questions they want to ask. They can't ask about what scary thing they read in the paper the other day, about what their friend said about HRT. They want more time. There are lots and lots of women out there on HRT. What happened with hormone replacement therapy, which is what I'm referring to as HRT, is that back in 2001 and 2, we had 2 really big studies done which unequivocally showed that women that took hormone replacement therapy in the form of estrogen and progestogen came out with a slightly increased risk of breast cancer than the women who took placebo. Overnight, we went from women wanting it put in the tap water to everybody stopped prescribing it and women were too scared to take it. So it was a complete switch around. And it was absolutely true. The studies found that there were 4 extra cases per 1,000 with women who took HRT. What the headlines didn't say under the big headline of HRT increases your risk of breast cancer is actually, just listen to this, 5 times more many women every year in the UK die from heart disease, and estrogen protects the heart, and actually also it protects your bones. Look at all the women with fractured hips, fractured wrists, women who don't ever get fully mobile, go back to their workplace or their lifestyle again because of this. So HRT has got some pluses as well as minuses, but those were overlooked. And very quickly, just to put your mind at rest, the study was done many years ago, and the average age of the cohort of women was 63, which is probably a whole decade older than most of the women who are wanting to take HRT. Plenty of women in their 60s take it quite safely, but we're looking at initiating HRT, and these women were older, and they were taking high doses of synthetic estrogen made from pregnant mare's urine. It was called Premarin. It was all we had. We now treat women with body-identical HRT, not to be confused with bioidentical, which is also something you can research and look at, but that's not supported by the British Menopause Society. I'm a British Menopause Society registered specialist, so I am obviously following their guidelines as I would with the NICE guidelines. So we give women body-identical HRT, which means that the estrogen in it, whether it comes in a tablet, a patch, a gel, or a spray, is body-identical plant-based estradiol. Most of the combination HRTs have a synthetic progestogen in. Very low dose, not as high dose as the contraceptive pill. Progestogen is confusing. Progesterone is what we make in our bodies, and progestogen is the synthetic form of that we put into medications. There is now also a way of taking natural progesterone for your HRT if you want to do that as well. So you can make this as bespoke and body identical as going into the health food shop and buying something that is marketed as a natural therapy. HRT can be natural. So very quickly, just to look at the risks of breast cancer, which is the one that was the main concern from those studies. If we look at women between the age of 50 and 59, for every 1,000 women per year in the UK, there will be 23 cases of breast cancer. That is our population risk. If you add in HRT, you're going to increase that by 4. If you drink 2 units of alcohol a night, you're going to increase it by 5. If you smoke, you're going to increase it by 3. If your BMI is 30 or above, you're going to increase it by 23. And if you exercise, you decrease it by 7. So the point of me saying all this is not a lecture. This is about the risks we take in life, and that it all is perceived as very different when somebody prescribes a medication, or that prescriber is wanting to prescribe a medication and knows that risk. We've all got risks. We take risks every day. So it's taking on board, how bad are my symptoms, how awful I feel, I can't manage my life, I'm driving everyone mad at home, driving myself mad, everything's falling apart, I need some help. I'm going to take on board the slightly increased risk of breast cancer. I'm going to decrease my lifestyle risks by getting healthy, getting fit. I'm going to take a low dose of hormone replacement therapy, and I'm going to do my breast checks, and I'm going to go and have my mammograms when I'm called, and just be what we call breast aware. So it was the breast cancer risk that scared everybody, and everybody stopped taking it. And I would say that a whole generation of women, my generation, probably have been deprived from HRT when actually most of them would have been perfectly safe to take it. If you have 2 first-degree relatives under the age of natural menopause who've had breast cancer, you will probably have a slightly increased risk yourself. Taking HRT doesn't make that risk even bigger, it's just that you're starting from an increased risk. So quite understandably, and I would understand, you probably don't want to take it because you've got enough risk already. You may want to, but I understand that that's a very real fear for women. If your mother had breast cancer, or your aunt, or your grandmother, and particularly if they were postmenopausal, that does not increase your risk. You have still got population risk increased by those lifestyle factors that we talked about. It may psychologically increase your risk, and if you're going to be really stressed by being on HRT because your mum had breast cancer and you remember all that and you don't even want to be, if that's going to stress you out by taking it, then HRT is not going to be helpful for you at all. But it's about me letting women know that this is safe, and we can give it in low doses, and we can give it through the skin. And that's a really good way to give any kind of medication. So when we swallow a tablet, it's got to go through our stomach, it goes through the liver, through what we call the first pass system as we metabolize it. And there's evidence to say that we don't metabolize anywhere near all of the drug that we swallow. If we have it through a patch or through some gel or a spray, we're going to get a lovely even absorption of the medication, and we can therefore keep the dose as low as possible. The lower the dose, the lower your risks. So one of the things I wanted to talk about quickly, are we all right, Mickey, for time? Can I have a few more minutes? We're fine. Okay. So one of the things I wanted to talk about was when shall I start HRT? I know a lot of women go to their GPs. I often get this and they say, I've been to my GP and I've said how I'm feeling, but my GP said, well, you're still having periods, so you're not in the menopause yet. So remember what I said at the beginning, that you can be your perimenopausal or postmenopausal for any or all of those years. And for the duration of symptoms for most women averages at between 4 to 7 years. Some women will go on for 10 years plus, and we all have met ladies who are in their 70s and 80s who say they still get some hot flashes. And I'm sure they do. So it is very different for different people. So if you have got symptoms, even if you're having a period every 4 weeks, let's say you're 46, you're having a period every 28 days, it's just as it always was, but you're getting symptoms and you want to explore what's going on, it is worth having a consultation with your doctor. And the very good thing about hormone replacement therapy is that if you take it for 3 months, you will know if it's going to make you feel better. So many conditions that we treat, and we have to treat, so for instance, if you've got high blood pressure and you take blood pressure medication, your prescriber, your GP or your nurse will review you to make sure that your blood pressure is well controlled because you're taking the tablet. You probably wouldn't be aware of whether it was well controlled or not. The good thing about hormone replacement therapy is that if you take it, I can almost guarantee it will make you feel better, although some people do get some side effects from it, but you probably will get rid of some of your symptoms. And if you don't feel any better at the end of those 3 months, you're not going to want to take on board any risks to do with breast cancer or anything else if it's not doing what it says on the tin. So taking it for 3 months would give you a fair trial of, or perhaps even 6 months, of whether this is going to be the right thing for you. And I would ask for body identical. I would always opt for taking it through, well, I wouldn't always opt for taking it through the skin. There are some women for whom putting on a gel or a spray or changing a patch twice a week is going to be a thing in a busy life that they're just not going to remember and do. So for some people, taking the tablet is absolutely fine. There is a slightly increased risk of clot if you take it in tablet form and if you've got an increased risk of clot. So we've all got a risk of having a clot. as we get older. But if you have got definite risks, and you would talk about that with your doctor, I would say don't take it in tablet form, but taking it through the skin won't increase the risk you've got. That's your risk, and that's how it is. So it's safe to start at any point, and within those years, and often we start women who are just in their early 40s, and the NICE guidelines say that hormone replacement therapy is the best possible treatment for those women with symptoms for short-term use only. So they call that 5 years. We used to have an arbitrary figure of you need to come off it when you've been on it for 2 years or by the time you're 60. We no longer follow those guidelines. We review women every 6 months annually to make sure that everything's all right. And if nothing's changed, as in they haven't taken up smoking or stopped exercising or doing that sort of thing, and we look at their risks and benefits and we talk them through it. So just a little bit before I go on to my last bit, which is about menopause myths, I just want to talk about weight, because I know that's a really big issue for a lot of women and men, and that we all gain weight as we get older. That is natural and normal. And when we look at toddlers, for every 1,000 calories they eat running around, they burn up 700 calories for every 1,000 that go in. When you get to 40 plus, whether you're a man or a woman, you can completely reverse that, and you're probably only going to burn up 300 and store the rest. As we lay down fat, we lay it down particularly around the central organs, and you only need to have a little bit of fat on your pancreas, which is responsible for shifting insulin when you take in carbohydrate. Let me unpick that a bit. I've gone a bit fast. When we eat, and we eat carbohydrate of any type, whatever you're eating, the pancreas pushes out some insulin, which helps us metabolize it and break it down. If we get a little bit of weight around the central organs and that sits on the pancreas, it makes it harder for the pancreas to shift that insulin. And the only way to get that working is to get your heart rate up and get out of breath. So you've got to get out and exercise. I fully appreciate that is not possible for everybody. So it's looking at what you can do coupled with healthy eating. HRT will not make you lose weight. It will make you feel better. So you may feel more inclined to exercise. You may feel more confident about it all. But although we gain weight as we lose estrogen, sadly, because this is the way always, isn't it, that it works, putting it back in is not going to make us lose the weight again. And the other thing to address that a lot of women talk to me about is low libido. That causes relationship issues. Unfortunately, that is part of the depletion of hormones. We lose testosterone. We tend not to think about that because we think about it as a male hormone. But when we lose our estrogen and progesterone, we are losing testosterone, and that has an effect on how we feel about things, including libido. There isn't a quick fix. A lot of women like to try testosterone. It can't be trialed until you are taking estrogen, until you're re-estrogenized again, because your body won't utilize it properly. And it is unfortunately not available on the NHS for women. So it is always going to be something that you would have to visit privately. So those are two of the big ones that women ask me about weight gain and about mind fog. They lose their words. They can't remember what they're saying. These are all signs of your estrogen depleting, and it is a natural phenomenon. And remember, testosterone you can talk about testosterone once you're re-estrogenized and you're feeling better. So a little bit about menopause myths. The ones I've written down, the questions I've had, is it dangerous? Well, I think we've covered that. There are risks. Just like when you drink a glass of wine, there's a risk attached to it. Are you going to take on board that risk? Will it suit you to have that risk? Does it just delay menopause? That's one comes up such a lot. HRT doesn't delay menopause. It masks your symptoms. The symptoms will go on for average between 4 and 7 years. When you and your prescriber decide it's time for you to come off HRT, you can either come off abruptly or you can come off gradually. You can imagine most women would rather come off gradually. And if your symptoms come flooding back, then you are still symptomatic. And again, agreeing with your prescriber whether you want to restart it or put your dose back up. If your symptoms don't come back, then at some point during the time when you are on HRT, your body's stabilized and your levels are now okay. So that poses another question that women ask me, well, how will I be okay when I haven't got any estrogen? We'll all have a bit of estrogen when we're postmenopausal, but we won't have those erratic fluctuating levels that give us these awful symptoms. So we won't ever have that energy and the feelings that we get from estrogen when we're younger, but we will adjust to that level that we have when we are postmenopausal. The other one is, my doctor won't give me a blood test. You don't need a blood test. I would want to do a blood test on someone younger than 40. I might want to do blood tests to see that there wasn't anything else going on, but you don't need a blood test to diagnose the menopause. It can be misleading. Hormone levels fluctuate. They fluctuate in your 40s, your 50s, your 60s, and so on. It can be misleading about the diagnosis. If you have those signs and symptoms, we know what's happening. I send you off for an expensive blood test and come back to find that your estrogen is low, that your follicle stimulating hormone level, which goes in the opposite direction, is high, and your progesterone is where it is, and I would think, well, yes, that's exactly what I expected. So we treat according to symptoms, and we maintain treatment according to response to therapy. So you may come back after 3 months and say, so many things are better, but so many things aren't, and we might need to tweak things. I also hear people say, or I've read, HRT either suits you or it doesn't. I would argue with that, and I would say there are so many different ways of giving it, and different types of giving HRT, that actually I think if it doesn't suit you and you don't feel better, or, which I alluded to earlier, if you don't feel well because you're getting a few hormonal side effects, there are different ways of giving it. So return to your prescriber, don't give up. Talk to somebody about it and see if you can make this better for yourself. But I really feel what I want to get across is there's help out there. We mustn't ignore it. It's a bit of a sort of silent epidemic, really, because I think women are suffering in silence and dealing with all sorts of things that menopause is not responsible for every health thing that we have in our 40s and 50s, and HRT will not fix it all. But if we feel better in ourselves, better able to cope with the everyday stress of life and work and the things that we're doing, it may be worth that small risk, if there is a risk for you, of taking hormone replacement therapy. How does that sound, Mickey? Let me have a look at the questions.
I don't think we've actually had any questions in at the moment. But that's not to say that we won't get any when people rewatch again on YouTube or on Facebook later. But that's been brilliant, really informative.
Thank you. Is there anything you can think of that I may have left out, or that I may have skipped over? Because I talk about it all the time and it's what I do and think. I may have skipped over something that is incredibly obvious that people are going to ask. So, but that's fine. I'll look at Facebook and I can do some questions.
I think you've covered it all. And one question: if you have no ovaries, where else would your body be able to produce estrogen post-menopause? Am I right in thinking that you do store some in your fat cells?
You store some in your fat cells, and so everyone will have different levels of that, and it will fluctuate. And I'm really glad that you asked that question, whoever did, because what I didn't say, and it is slightly to do with what you've asked, is that if you've had your ovaries removed, and some women will have had their ovaries removed very young, you need to think about not what are the dangers of taking HRT, but what are the dangers of not taking it. So remember that women who lose their ovaries young, or they have an early natural menopause, they have lost their estrogen, their levels of estrogen they are supposed to have. And we are designed to have those levels until we are this magic average age of 51. So women who are sort of 42, 43, or a bit younger, who say, oh, I'm not going to do that, I'm just going to do it naturally. If they were to take HRT, they will not increase their risk of breast cancer significantly, because they're supposed to have those levels of estrogen. What they will put at risk is their bone health and their heart health and their colorectal health. So estrogen is really good for gut motility. There's evidence that colorectal cancer is going to be improved by taking estrogen. So if you're out there and you're young and you've lost your ovaries, well, I don't mean lost them, if you've had an early menopause, I think you need to think about what you could possibly do. I wouldn't be worrying about women who are sort of 46, 47 and have done that. That's okay, although they could benefit from HRT. But if you've had a very premature what we call premature ovarian insufficiency, you need to talk to somebody about what you need to replace. And probably those girls need testosterone as well. You'll probably find a lot of them are absolutely worn out. They feel old, they feel, I don't mean they look it, but they feel exhausted by everything. So they need to get those hormones put back on board.
Definitely.
But I've forgotten what that question was about the yes, you'll have estrogen in your fat tissue, and so there will be some of it circulating.
Brilliant. No, it's brilliant to talk about it. It's a subject that's close to my heart. Obviously, I went into menopause quite early after a hysterectomy at 38. So the benefits I noticed straight away from almost taking HRT from 2 to 3 months in, because I was about 2 years without it. but then you notice the achy joints and the no sleeping. And I take the gel now, and it's brilliant because you can just rub it in on your arms or on your legs, and it's done. You just do it after a shower, and it's done and forgotten about. And you can tweak it as well to suit. Yeah, so it's brilliant.
Actually, if you've got 1 minute, just for me to clarify, in case anyone's wondering this out, if you've had a hysterectomy or you've got a Mirena coil in your uterus for contraception, you only need estrogen, which is what you've just said.
Yeah.
If you haven't, if you've still got an intact uterus, you need estrogen with progestogen. So there's those, I think I did speak about it briefly earlier. There's two different types. And there are types of HRT that give you a period and types that are continuous and are bleed free. And you'll all be out there now thinking, give me the one that's bleed free. But it has to be done at the appropriate time. You need to be postmenopausal to have the bleed free one, or you'll get lots of bleeding all over the place. But that's something to discuss with your prescriber. There's lots to learn about. And the other thing I would say is, if you do make an appointment with your GP now, and you get an appointment to talk about HRT, don't be disappointed if you're not given a prescription there and then. You may be, it's quite a big thing to do in 10 minutes in a short appointment. So don't be disappointed straight away. Go away and do some research and think about it. And if anybody is interested in making an appointment with me, I obviously do now do virtual work. That's been a teeny weeny silver lining of COVID, if ever there could have been one. So I am seeing women in the virtual way. And although, of course, I realise there's a cost implication, it doesn't have to be ongoing. So I do an initial consultation. And if I prescribe for ladies, I do like to do a review at 3 months. But after that, their care can be transferred back to their GP. So it's not an expense forever, unless you want it to be. So thank you for letting me say that. Thank you, Nikki.
No, that's fine. Oh, just one further question, just going back to the estrogen. So if there's enough estrogen in my fat, is there enough estrogen in my fat to help keep bone density?
That's really interesting, and there probably wouldn't ever have been done any scientific research on it. But if you're eating a healthy diet, getting sunshine when you can, doing weight-bearing exercise, walking is good, skipping, get yourself a skipping rope if you don't want to jog around the block. If you can, I realise there are people out there who've got ailments that they can't do this, but your bone health could be perfectly fine. And obviously we wouldn't put women, there could be an argument for saying, well, look, by the time everyone's 80 or 90, their bones are going to be so frail, why not have them all on HRT? But then you're thinking about the risk of breast cancer and the other risks. It's not, HRT is not first-line treatment for bone density. It's just that if you have a risk of osteoporosis, or you are already osteoporotic and you're on HRT, that's going to be a bonus.
Okay, so, brilliant.
Does that answer that?
Yeah, I think that is all the questions. But yeah, just thank you so much again for joining us.
Oh, thank you. Thank you.
Really interesting, loads of good comments.
Good.
And hopefully we'll get lots more views on YouTube and Facebook later on.
Good. And please don't forget, everybody, have a look at the British Menopause Society and Menopause Matters. Loads of important information out there for you. Okay.
Fantastic. Thanks again, Teresa.
Thanks, Mickey. Take care.
Bye-bye.
Bye.